Greetings, I'm Dr. Pang Hong Wu from Ng Teng Fong General Hospital, Singapore. Thank you, Asean Misst, for inviting me to share my experience with the treatment of L5S1 pathology using transforaminal endoscopic approach. I will also use this opportunity to discuss the advantages of another favorite approach of mine, the contralateral approach. I work as a consultant in National University Health System, Jurong Health Campus, Orthopedic Surgery, Singapore. In my population, we take care of about 12% of the Singapore population and 7% of the elderly population in Singapore. In my practice, I do about 60% of my cases with the endoscopic spine surgery, 70% of them are uniportal, and 30% are biportal surgery. Most of my surgery involving stenosis decompression, as well as discectomy, and then I do some endoscopic fusion as well as cervical thoracic cases. This is my conflict of interest. And I would like to acknowledge my mentor, Professor Hyu-Sung Kim from Gangnam Nanori Hospital, Seoul, South Korea, who have taught me endoscopy and also assisted me with some slides of the talk. Generally, the reasons why we do endoscopic surgery, be transforaminal or contralateral interlaminar approach, is to have a target-oriented surgery, preserving motion segment, and soft and bony tissue preservation, allow mobility of equipment and scope, and allowing shorter hospital stay, less perioperative pain, less anesthesia, and small cuts with huge rewards. However, in L5S1, unlike others, lumbar levels, there's a high iliac crest or narrow pelvis. There's also possibility of uprising ala close to the large transverse process, narrowing the window further. A wide foramen and a large L5S1 facet and a wide interlaminar window. These are the specific characteristics of L5S1 level. As you can see from this picture, which is kindly provided by Professor Kim, we have a various type of this, be central, foraminal, upward migrating and downward migrating disc. As we target the scope, we realize that the upward migrating discs are difficult to assess for various reasons. One, the interpedicular distance in L5S1, although it's wide, however, it is at the inclination due to the presence of iliac crest. The height of iliac crest really dictates the inclination that we can, Cavalier caudal inclination that we can give in the endoscopic transforaminal approach. At times, the large TP and large ala further limit this window of for the scope to manipulate. So I find that caudal migration, central migration, foraminal disc, and extraforaminal disc are easier than upward migrating disc in transforaminal approach. A narrow pelvis also further complicate matters if you want to do a central disc. So as the distance from the iliac crest is very narrow from the central disc region. So all this together with a wide foramen, which means that there might be a lot of bony resection required for central disc or the foramen paracentral disc. We may consider using interlaminar approach for central and paracentral disc or upward migrating disc, since it has a wide interlaminar window where we can explore. However, our topic today is on transforaminal endoscopic surgery, hence my focus will be talking about that. We first analyze patients who have L5S1 prolapse disc on the MRI and look for any contraindication for transforaminal approach, such as exiting nerve root abnormality, using trigonometry, especially the tangent, to calculate the distance from the midline for the approach. Using the AP lateral view, we look out for the iliac crest level, pelvis size, and whether there's for level counting, lumbarization or sacralization. On the lateral view, we'll also look at the size of foramen and the level of iliac crest. And you can see here, I used the trigonometry and calculated about ACM for the case I'm going to present later. Girish and his group, Dr. Prasad and Girish and the Indian group actually found that using various parameters to assess whether the height of iliac crest can be suitable for transiliac approach or suprailiac approach. They basically look at the tip of the height of the iliac crest in the AP lateral view, and looking at parameters such as the upper end plate discal level, as well as that of the lower end of the L5 pedicle. And on the AP view and on the lateral view, looking at the lower end of the pedicle level to dictate whether it is suitable for suprailiac or transiliac approach. And they find that for the type 1 and type 2, probably suprailiac is possible. For the type 3, I think they recommend transiliac approach. For type 3, meaning that the iliac crest is way higher than that of the pedicle line, and it's also way higher than that of the inferior aspect of the pedicle. For transiliac approach, sequential reamer is needed to make a window of the iliac bone after infiltration of LA to create a space through the iliac crest into the transforaminal window. And in this anatomical study by Osman, they find that this transiliac window is about 4.1 cm anterolateral to the PSIS, and it's posterior to the sacral ala and cephalic to S1 pedicle. The transiliac tract does not violate the retroperitoneal space and is safe distance from the lumbosacral trunk. And actually, it's also far from the gluteal neurovascular bundle. Personally, I do not do transiliac approach. I mainly do suprailiac approach. If there's a need for transiliac approach, I tend to do interlaminar or interlaminar contralateral approach. I published a few articles on the manual palpation technique together with my colleagues from South Korea and India, and I will be sharing with you in the next few slides. Basically, this is also seen from our article in the Journal of Spine Surgery. Basically, we want to look at the L5S1 Cambin's triangle. First, we mark the midline of the patient, and then we mark the discal space, the superior end plate of S1. Then we mark the approach from the AP view. I tend to do it in a slightly cephalic caudal and lateral to medial direction, as seen here. We mark the iliac crest. You can do that under fluoroscopy or under manual palpation. I tend to do it with fluoroscopy. We manually palpate the muscle margin. The incision approach should be medial to that of the lateral, the margin between the erector spine and the soft tissues. And on the lateral view, we turn to lateral view and look for the approaches again to the Cambin's triangle. And we mark the posterior spinous process in patients who would like to do a para central disc. And we measure distance from the midline. This I hope match the preoperative distance, which is X. This X distance can be ranging from 6 cm to 15 cm depending on the position of this and the physics of the patients. I do not recommend absolute numbers when you do endoscopy because every patient's pathology of the disc location as well as the physics is different. So I've done transforaminal 15 cm for midline, and I have done 6 cm for midline as well. For the handling of the foramen, superior articular process, foraminoplasty technique can be done inside out, outside in, and mobile outside in. I have described that in my articles as well. I think for the mobile outside in, you can use a straight burr articulated burr. It'll be useful with side firing laser, although I do not tend to use them. Front reamer and side reamer has its advantages, and we can analyze them another time. So to discuss this the case of a right last mobile disc, a 37-year-old who has a right sciatica with a strict leg raise of 30 degrees, has a foraminal disc in the right L5S1 region. She has pain and a relief by sensory nerve root block for 3 days only, and the pain recurred, failed conservative treatment. I applied my trajectory as described just now, and we did a transforaminal approach for this patient. It was 8 cm from the midline. First, we exposed the facet joint. The 9 o'clock position is caudal. 3 o'clock position is the head, and 12 o'clock position is the back. We expose the facet joint with the radio frequency ablation, and then we do a foraminoplasty. As I mentioned, I tend to use a mobile outside in technique, direct visualization of the superior articular facet, and do endoscopic drilling with a 3.5 mm burr. I do release the foraminal ligament by using a 90-degree Harrison punch, and then this space is visualized. Yes, you can see that the exiting nerve root is directly visualized in this approach, as it is an ACM from midline, and it's a foraminal disc. So we protect the exiting nerve root with the tank and remove the disc from the disc space. I use Indigo Carmine pre-op to light up the disc better. The nerve root is really closely adherent to the foraminal disc, so I use the radio frequency ablation to release the adhesion from the disc and the nerve root. This patient, mind you, had a nerve root block before, so adhesion can be common after a nerve root block. And we use the probe and gently lift the exiting nerve root away from the right L5S1 foraminal disc, and then we perform a discectomy. After a few bites of the discectomy, the nerve root can be manipulated further, and more discectomy can be performed. You can also use the tank of the retracted tube, working tube, to explore the disc inside. We tend to do a discectomy sufficient enough to prevent recurrence. Loose fragment, which is lighted up by indigo carmine, is performed. Release and discectomy is performed on that. You can do annuloplasty with the radio frequency ablation as well, shrinking the excessive annular soft tissue while performing discectomy. We explore both the exiting nerve root and the traversing nerve root. If necessary, more foraminoplasty can be performed, and more foraminal ligament can be released. For patients with lateral recess stenosis, you can also use the articulated burr or using a straight burr with mixture of side firing laser as well as Garrison Ronger to perform decompression of the lateral recess. Not necessary in this case. Now you can see the traversing and exiting nerve root well decompressed as we pull out the scope. It is no nerve damages, and no excessive bleeding. Transforaminal surgery is very nice. For this patient, she choose GA. I tend to use LA sedation, and in this case, I didn't use ropivacaine injection and intra-op, and he developed a right L5 dysesthesia. It's a grade 2 dysesthesia, but MRI looks like fully decompressed, so I give a sensory nerve root block post-op day 1. That block, and the patient subsequently has complete relief of pain, and is very happy with the surgery. But she has a few days of she has post-op day 1, she has dysesthesia, and I would like to discuss about that. In transforaminal surgery, it does happen, and I published that in with my colleagues in the Indian Spine Journal as well. One of the complications is post-op dysesthesia. It presents really usually dermatomal distribution of hyperalgesia or allodynia in a particular dermatome, in this case will be L5. And the MRI post-op does not show any significant compression of neural element. There is a quick relief of the diagnostic with a diagnostic or therapeutic nerve root block. I felt that the causes can be radiofrequency ablation, retraction of the working cannula on the nerve, or even manipulation of the probe. They have good prognosis, and with conservative treatment, some of the colleagues may not agree with nerve root block post-op, but I tend to do them and relieve the symptom early so that they can get on and move and do their daily activities early post-op. So in this case, I've highlighted with the Indian groups, this is actually a suprailiac approach that we use, and she's actually a type 1 type of pelvis, iliac crest. I tend not to do transiliac approach, so I do not do type 3. For the type 2, I also have a low threshold of doing the interlaminar approach. For me, I feel that the advantage of transforaminal approach, of course, LA can be given with sedation. It is also easier for assessment of Far-Off syndrome extraforaminal disc. There's a less ability to decompress in the central and lateral recess stenosis, in my opinion. There is early direct visualization of the exiting nerve root, and you can encounter traversing nerve root late. It is a technique that a lot of endoscopic surgeons are familiar with, and we can able to do LA sedation. Another technique that I will be going through later will be a contralateral approach. This approach, we can do a central lateral recess and foraminal stenosis decompression at the same time. We do not really need to touch the exiting nerve root most of the time. And we can, however, we will be encountering the traversing nerve root early. And also there's a steep learning curve in contralateral approach, as it's not a traditional endoscopic approach, but it needs to be done on the epidural on G8. So for transforaminal and the contralateral approaches, as highlighted by these two landmark paper. Earlier on, my mentor, Professor Hugh Song Kim, published a earlier series as well with Dr. Bai Park and his group, highlighted the topic in ACTA and on how to perform this double crush syndrome. Essentially, this is the differences in terms of learning curve. I think the contralateral approach is kind of not so familiar with for most endoscopic surgeons, so it's a difficult learning curve, but it can although it can do extraforaminal decompression, can be difficult for early adopters of this technique. But however, intraforamen or lateral recess is very good. And there is very minimal facet joint violation. However, they need epidural anesthesia. And this is a video of how it's done. Basically, we start from the contralateral side, meaning if we do a right L5S1 foramen, we will be starting from the left. We target the base of the spinal process. We do a decompression, and then we change to a smaller working channel. We expose the contralateral. We expose first the base of spinous process, we drill through it and work underneath the sublaminar region. Then we look at the contralateral superior articular process. We do a flavectomy and expose exiting nerve root. We do a foraminal decompression by drilling the superior articular process of the contralateral side. And then underneath the exiting nerve root, we have given indigo macama, usually it's lighter in blue, and then we can perform a discectomy. As you can see here, you can see the exiting nerve root. We do not need to retract the exiting nerve root while we perform this surgery. This scope is tilted such a way that the exiting nerve root is at 12 o'clock position, and we can do a full release of the contralateral side, and we can see that there's a free and pulsating exiting nerve root. Using the X-ray, you can guide ourselves all the way to extraforaminal region, and you can see that it's well decompressed from the central, lateral recess, and the foraminal and extraforaminal region. And you can see from the MRI that this direction of decompression is well decompressed. With the study that we have done with my group, Professor Hyun Kim, Jim Kim, and Dr. Itae Zhang, Professor Itae Zhang, we felt that both DLD and ICELF do contribute to post-op dysesthesia. However, we find that the higher grade post-op dysesthesia, meaning grade 2 or grade 3, where essentially there is some sort of dorsal root ganglion, either neuroplexia injury or true injury, is higher in the transforaminal group. Although there's no statistical difference between the two groups, but we can see the clinical difference of up to 12% in transforaminal group as compared to interlaminar contralateral group. There isn't much study. In fact, it's one of the few studies that ever compare dorsal root ganglion post-op dysesthesia between the two approaches. So the literature is still not robust in this discussion. So we would take with more studies in the future to evaluate that. The effect of transforaminal and contralateral approach on the dysesthesia. However, in patients with nerve root anomalies such as conjoined nerve root, duplicate nerve root, or anastomosis of nerve roots, it is advisable to not attempt transforaminal approach, especially with duplicate nerve root, because the risk of post-operative dysesthesia or nerve root injury is very high. So in my opinion, in encountering L5S1 prolapse, we look at whether it's a challenging pathology or challenging physical anatomy. If there is a foraminal disc, then it is in the area where both the contralateral and transforaminal approach can be accessible. Contralateral approach have in our series less risk of post-op dysesthesia, but there's a steep learning curve in the contralateral approach. And extraforaminal disc only, I think transforaminal approach have an easy access. And as long as we take care in handling of exiting nerve root, I felt that we should give sufficient sensory nerve root block, even in GA cases, in these patients who need to manipulate the dorsal root ganglion. Upward migrating disc, I feel that the interlaminar approach is good. The central disc as well. I find that there's limitation in transforaminal approach, or there's excessive ventral vasectomy is needed to get through the central region of the disc. So I do interlaminar approach or biportal approach for this group. And if there's a concurrent stenosis, interlaminar approach is preferred, or biportal approach can be done. I feel that they are efficient in removing the ligamentum flavum as compared to transforaminal approach. Of course, transforaminal approach for patients who cannot tolerate GA is also an option for for unilateral stenosis with prolapse disc. In patients who have high iliac crest, high BMI, transforaminal approach can be challenging. I do not feel that it's contraindicated, but it can be challenging. So based on your experience, you assess whether you should be doing them transforaminally. For narrow foramen and far out syndrome, such as TPA stenosis, Bertolli syndrome, I find that transforaminal approach will be more proficient than contralateral approach. That's my own opinion. You can do that using the UBE or microscopic as well. But I personally like the use paraspinal stenosis scope and the transforaminal approach. Essentially, these are the few readings that you can read regarding my talk. It's published online and it's open access. Thank you very much for giving me this opportunity.